I'm going to do, or what I'm hoping to do, is exactly what Bogdan just said. I've tried to integrate what you just learned from Giovanni into an application of a support vector machine applied to 3D brain scans in the clinical setting. So my background is I'm a psychiatrist working in a memory clinic, but as Bogdan already mentioned, I was working with him and Richard and John Ashburner in London for a couple of years, and so this is what I'm trying to do. So this is a brief overview. I'll talk about what we need in clinic, what we currently have, what we do not have, but would like to have, and in practice, what these next steps could mean. These are the clinical needs, and again, this is something you learn from Giovanni. Clinicians are simple-minded and need tools that are immediately helpful for optimizing diagnosis. And here, in this context, optimizing could mean something is faster, something is applicable for with less effort, or with less money, or is simply more accurate. And if you put diagnosing into a wider context, it also includes the prediction of the future disease course or disease subtypes, which are important for the stratified inclusion into clinical trials, very much like what you've learned in the previous talk. And it could also include thereby the response to treatment. And this could potentially include also non-pharmaceutical treatments such as cognitive training, which is also a big topic in the area of mild cognitive impairment and dementia. For the clinical setting or for clinical tests, it may be less relevant to know exactly the biological basis of the tests you are applying, but I realized over the last years that some face validity helps to put it into the clinical routine. And when we are talking about the routine, the patients that are being seen in the memory clinic, they are far more heterogeneous than populations you have in clinical trials, which means they often have additional brain diseases, they tend to move in the scanner, and these are the sorts of problems I would ask you to solve, and maybe send me an email. Well, this is the vision we developed back then, and I would like to talk you through it. So the idea would be that there are specialized centers potentially located at university memory clinics that have the possibility to provide very certain diagnosis based on the biomarkers Giovanni just presented, and they could use this information to train classifiers, for example, based on MRI scans, and export these trained classifiers to the GP setting, where the great majority of cases are being diagnosed. It's very important to keep this, to always be aware of this distinction, that we always take a university hospital setting for granted, but this is not the reality. I mean, the by far greatest majority is seen outside. So what I would like to talk you through is the current processing pipeline. Say a few words, and this is mainly based on T1 weighted scans, and talk a little bit about alternative MR contrasts, alternative classifiers, and so on. And then with the focus on the ADNI dataset, which I understand you will also be using in the workshop, I'll say a few words on the effect of acquisition hardware and this heterogeneity which is introduced by that. So those of you familiar with basic processing of MRI scans may know this method called Voxelbased morphometry, which was introduced by John Ashburner now 15 years ago. The idea is basically you take a routine brain scan and separate it into its tissue types: grey matter, white matter, CSF, and background. You may, the experts among you will know there are slightly more sophisticated versions now, but this is basically the idea. And if you then at the same time perform a transform into standard MNI space, for example, you are able to directly compare voxel by voxel the various scans you have in your cohort. And this is usually combined with some recoding, where the intensity that you have, or the value you have in a given voxel, basically codes the local volume of that tissue type, which means a brighter, we're talking here about the gray matter, a brighter voxel in this image would mean more local tissue. And if we apply this to a scan of the hippocampus area, which is, I hope this is clear where we are in the brain here. It's cutting through the brain like this at about this plane, and you can see the hippocampus structure. I'll show you a nice slide, thanks Wolfgang, in a second. The idea is basically more brightness means more local volume, and so it's quite easy for you to compare the two images and detect the Alzheimer case on the left, because the voxels in the hippocampus area are less bright. And if you look at these slides now from a machine learning perspective, you'll see that the information is quite easily accessible already. You know, if you had native MRI scans, you would find a lot of differences between the scans resulting from registration differences related to non-brain tissue, or the vascular system of the brain, and this quite simple processing stream already reduces large amounts of non-pathology related imaging noise. And the method we applied is a support vector machine. I saw that on several posters yesterday, so it's quite a standard tool we use. And the concept is illustrated here, and it basically is multivariate in a sense that it integrates information from several voxels in the brain. And in our application, we typically use all gray matter voxels, which meant something like 20 or 50,000 voxels, and it's a supervised technique in the context, in the sense that it learns from training samples. And this is what I showed you on this concept slide, where we have the specialized memory clinic to provide these training slides and basically use them to define this separating hyperplane. And the definition of that hyperplane, or the parameters, will then be applied to routine scans from the clinical routine outside specialized centers. And there's a certain probability that you can compute with this support vector machine. It's not as elegant as what you can get with related methods such as Gaussian process classifiers, but this is what we used at the time to give you a degree of certainty. So how certain is the computer that it has got the right diagnosis? Now one point is, what is the best information that should enter such a classifier? And Giovanni mentioned a number of methods. For example, the PET methods allowing you to measure brain amyloid, or glucose scans that detect neurodegeneration quite directly. But there's always a trade-off between the level of information that is contained in a method and the difficulties to get access to that. You know, so it's not feasible to get a lot of PET scans outside specialized centers. So we always have to keep that in mind. But basically, there's always, I mean, the best methods are those that have a high degree of relevant information compared to noise. And this is just an overview summarizing papers. You know, the main message is that for neurodegenerative diseases such as Alzheimer's dementia, you'll find that the gray matter segment is quite informative and probably best used if you have to consider this trade-off between getting the ease of getting access to the data compared to the wealth of information that is stored in these images. And that makes sense given that it's the neurons that are in the gray matter, and they are the ones that degenerate. But there is, you know, if you look into details, I mean, there is some good data coming out of diffusion-weighted scans as well. Well, there's now a range of methods in terms of the pre-processing, so how you extract data from the images and also into which classifier you put them. John Ashburn was always pointing out to something called Occam's razor, which means if you have several methods, it's usually the case that the simplest method is the best. And here I'm talking about the problem of overfitting and the difficulties of generalizing to new data. And there was, in 2011, there was a nice paper comparing a lot of different pre-processing methods and found that these relatively simple method we were using related to VBM actually best performed in generalizing to other data. And this is, just to illustrate this point a bit more. Giovanni mentioned that we have a diagnostic certainty of maybe 70–80%. So those cases in the ADNI set, so the early stage ADNI data, they are also likely to have something like this degree of certainty to, let's say 70–80% correct if you take the pathology as your gold standard. But if you then have a classifier that performs 100% accurate on these data, you're of course wondering, what does that mean? Is it really picking up AD-related pathology? Which can't be the case if you know you only have that present in about 80% of cases. And I would say this is an indication of overfitting. I won't go through all possible data extraction and pre-processing methods, but some key elements are mentioned here. Several groups focus on the hippocampus area and shape and deformation information extracted from that. Then there is the cortical thickness data, which provides interesting results, and the CAD Alzheimer's Challenge recently finished and is currently publishing a comparison, a head-to-head comparison of different processing methods. This is something, if you're into that, you should look up, because it's the nice thing is that they provided data at a completely independent training set, and then you had to upload your own method, and they applied it to test data. So it's fairly unbiased and therefore quite interesting. And this is what I mentioned, Ahmed Abdul Kadir. You'll meet him tomorrow in the workshops. This is work he did with the ADNI data set, and this is data set applied from a high number of centers, and they all use slightly different scan settings. And here the purpose of this study was to quantify what is the effect of using different field strengths or different receiver coil systems, or indeed just a different scanner vendor, on the diagnostic accuracy of separating Alzheimer's patients from controls. And because by design the ADNI study had acquired 2 T1 weighted scans from each subject, we were able to compare the effect of just scanning and rescanning the same subject in a scanner compared to scanning the subject in one scanner and scanning it here in this case a 3T, so 3 Tesla scanner, to quantify that. And the message what we concluded here, and this is very much in line with Richard, with what Richard said in the first talk, that the number of training data matters, and even if even if it is slightly homogeneous in terms of acquisition parameters, it is size that matters here. And this is also illustrated here. So you have a far greater, this is basically, this is for those who are familiar with the support vector machine, this is the change in SVM decision value related to diagnosis. So this is the difference between controls and AD, and these relatively small changes, here is the 0 line, illustrate how little these decision values change if you scan and rescan the same subject in the same scanner, or if you rescan the same subject in 2 different scanners. So it's fairly stable compared to the disease.
Can you quantify when you say sample size? Can you quantify it? What's the, let's say, minimum sample size you need for training?
Yeah, I mean, we did a study with post-mortem cases, and because it's difficult to get hands on these data, we had a group size of, I think, 20 per group. And we, for the ADNI data, we did a little plotting, how much the accuracy changes when you take out 2 cases in each optimization, in each training round. So we systematically reduced the training set. And you saw one thing you saw is the more scans you have, the better. And this is true for even if you go well into the many hundred cases. But if you, on the other hand side, if you reduce to below 30 or 25 cases per group, the variability of the accuracy increases substantially, and then you see a deep drop below 20. I have this slide, not in this presentation, but I have it here, so if you're interested.
I was wondering what kind of features you use here, because obviously if you use voxel intensities, there will be a massive difference between different scanner systems. If you use something like gray matter probabilities, it might be more similar.
That's right. So we use gray matter probabilities. Yeah. I mean, this is absolutely true. I mean, the intensity differences between scanners are substantial. You need this type of pre-processing. Other questions?
I probably missed it, but what is the accuracy of this type of classifier that
yeah. I mean, the accuracy varies a lot, for example, with the disease stage. So with these relatively far progressed, pathologically proven cases, they had, I'm not sure if you're familiar with these mini-mental score, so they had a score of about 20, so it's a fairly advanced disease. There the accuracy was about 90%, and with the ADNI cases we get something like around 80–85% accuracy. But I also have this have one slide where a lot of methods are compared, and you can see that maybe with the original ADNI set, before they included all this extra information from PET data and so on, probably you couldn't get much higher than these 85%, because this is where the gold standard is.
So there's another interpretation of that result, which is that it's 100% accurate, but there is a 15% contamination of your sample of AD. Okay? So it may be that the SVM is a better way of classifying the disease than the clinical way. And that's a significant clinical research project which someone somewhere will have to take up on here. And it will involve getting the pathology somewhere, either non-invasively, through the pattern of atrophy or something like that, or simply by following patients like Klöppel did with his frontotemporal dementias for 10 years and seeing what the pathological end result.
Yeah, but I think he said that the 100% is probably due to overfeeding. So that means that...
if it's not 100%, it's 85%.
It is, yeah, that's right.
So the accuracy is 85%. Now what I'm saying is, one interpretation is what he said. Another interpretation is that the accuracy is actually 100%, and the remaining 50% are not Alzheimer's disease. They are dementia, which we think is Alzheimer's disease, but until we get the pathology, we won't know. Okay.
But I think this is actually the point where I think these unsupervised methods have their place, because I mean when we have this high number of wrong diagnoses in training data, then we can't really solve this, and we can't really solve this problem.
Exactly.
And this is just the, because I had the time to put it out now, this is a comparison between all methods. This is applied to the ADNI data set, separating Alzheimer's disease from controls, and you can see the range of possibilities, but the overall accuracy, and now this is a combination of sensitivity and specificity, is relatively similar with all of those, probably because this is where the gold standard is. But remember, the ADNI data quality has improved because they systematically added information from other sources, such as clinical follow-up, which improves, and then these biomarkers you heard in the previous talk. Was there one more question? Did I? Oh, yeah.
You mentioned the variations on scan. What about variations in contrasting agents? Is that something that
you mean contrast? I mean contrasting agents. You mean really like? You mean because with special clinical questions you apply a contrast agent, but not if you are if your aim is to detect neurodegeneration. Are you really asking about contrast agents that you inject?
Yeah,
All right.
we don't do that.
No, it's not standard procedure for routine dementia scanning.
Just before we finish with the previous discussion, he's a modest man because he did the study where he took scans from patients who had pathology, but the scans were obviously done beforehand, and he ran the SVM, and he found a 95% sensitivity and specificity. So there is a serious question there, because it only takes 10 minutes to do a scan. It takes a week of highly complex clinical investigation to give the current clinical
values.
Thinking a bit about the Human Brain Project, big vision of bringing all these data in from different hospitals and so on. How much do you think this, your demonstration that the variation across hardware is less than the variation that you see from disease? Does that scale up if you're, rather than using quite nice research data, you're using kind of grungy clinical data that comes across?
I mean, I thank you for this question.
Yeah, that's what I'm wondering. Yeah, whether it.
I mean, because we were surprised how substantial this drop is. I mean, this is data. This is unpublished data from our from applying these methods to our memory clinic, and what you see. I mean, this is about the separation between Alzheimer's dementia and frontotemporal lobe dementia. And what you see here, I mean, is the accuracy we have with the training data, which is good, which is well in line with what other people find, so it's good. But you see a substantial drop when we apply it to our nice or not so nice routine data. And this is one of the problems I would like you to solve. So why is this? Why do we see that? And we don't. I mean, this is close to not really useful. While this type of accuracy is excellent if you want to separate these two types of dementia.
Are those pathologically verified?
They are some of the cases.
No, the top ones.
These ones.
Yeah.
Some of them are. None of them have really pathologically proven data, but some have PET biomarker data.
And the results of the other ones
These
are against that training set.
Yeah, this was the training set and this was the test set. Yeah.
So does that mean that some of those are neither?
You mean what? What do you mean neither?
Neither AD nor FTLD.
That's right. That's right.
That could be one answer.
Yeah. I mean, we also in this study we also applied multi-class SVM like approaches. So we had a range of possible diseases. So also included Lewy bodies disease, and we also applied support vector machine to the voxel level and quantified white matter lesions. But I won't have time to go through all these elements here. One thing is this study I would like to mention. It's an early version of Watson against the clinician. It is a comparison between the accuracy we got from the support vector machine and providing this exact same data to radiologists. And this slide, I think, is also important in context of the difference between a specialized memory clinic at the university and what you have in the primary healthcare system. So what you see on the left-hand side is a correlation between the experience here as percentage of brain scans in their daily workload and the accuracy they have with separating Alzheimer's, with identifying Alzheimer's dementia. And you can see there are obviously a lot of radiologists who focus on scans from the abdomen or the chest and rarely have to diagnose a brain scan. And in many of those reports you just hear this patient has atrophy, but it's not clear is that expected by age or is that beyond age. And this is really where I think the strength of this method lies. Because you can see when you have the real expert radiologists, they perform quite close to the performance of the computer algorithm. And I always like to mention when I show this slide, this is sort of an artificial situation where you only have two potential diagnoses, and this is why the computer algorithm is so very strong here. You know, it's not that we want to put all radiologists out of job. Probably in this context I could even say that. But it's being recorded now. So. This is why I didn't want to sign my agreement there. There was a question there?
Yeah, so I wanted to ask, is your method actually used in the clinic?
Yeah,
is there any close to being used?
We use that in the clinic, but we, I mean, until last year we retrospectively analyzed the cases, so we did not provide this, the information from the classifier to our clinicians, but as of January this year we have, we provide the outcome of the classifier when we have this panel meeting where we discuss all cases. Right. Well, this is just an illustration what the clinical routine is like at the moment at our hospital. So this is a case of a 82-year-old lady who basically says everything is okay, so she doesn't know what she's here for, but the relatives mention memory problems and impairment in short-term memory over the last years. But because she is still self-sufficient, we would not, strictly speaking, call that dementia, but query mild cognitive impairment as diagnosis. And here, for a clinician, the relevant question could be, what is this lady going to progress to dementia, for example, in 12 years? And this was one of the questions we tried to answer with this French. Shall I press this one? No, there's disagreement here.
The other one.
What then?
The other one.
On the right side.
Yeah.
All right.
10 minutes.
Yeah.
Okay. And this is what the clinical routine involves at the moment. So we have quite a labor-intensive cognitive test battery, which means 30 minutes of work for trained psychologists to get a feeling which domains in their cognitive performance are affected. For example, here you have the memory of learned words, and critically, here you have the recall of words, which means 20 or 30 minutes later, she's being asked, well, which of those words do you still remember? And this is how we currently diagnose an hippocampus impairment and thereby raise a suspicion of an Alzheimer's diagnosis. And for example, here, this is quite obvious. She was able to draw 11 of 11 pictures from rectangles, circles, and the like 3D plots, but she couldn't remember a single one 20 or 30 minutes later, and this was very clear evidence that this is a memory, this is a hippocampus problem, and therefore probably Alzheimer's disease. But this is how we diagnose Alzheimer's at the moment, and as I said, it's quite labor intensive, and this is something you can't be doing in a GP setting where you have nobody to do all these tests and no room to do the testing and so on. But with this, from this lady, we took an MRI scan, and this is what it could look like. This is actually the same patient a year in apart, 2 years, 1 year in between, and you would normally focus on this hippocampus area here, and then you have to rate the height of the hippocampus and the space you have here, which is part of the ventricles, and if you're able to see that there's a little gap here in the hippocampus, and this is what you would also need to rate to quantify the atrophy. And maybe you can see already that this is quite tricky, and this may be the reason why the level of accuracy correlates so much with the level of experience that the radiologists have. Okay, what question? Did you want to ask a question?
Yeah, it seems like there's plenty more else happening in the image here. Did she actually, did her brain change that much already, yeah?
Yeah. What, the ventricles...
Well, just by eyeballing, the ventricle, plus even the trachea motor.
Yeah. This is also because the two slides are not perfectly aligned, you know, but this is, you can see this here in these ventricles. I mean, it's quite good, but it's not perfect. But so this gives you the impression that there's a lot of happening. But again, I mean, from a radiologist's point of view, the challenging question is the atrophy you see up here. I mean, there's a lot of black here, which means a lot of water here. Is that really atrophy that is restricted to the hippocampus? And this is really the true challenge. I mean, it's quite easy to see that there's space here, but unless there is more space here than you can see in these areas, it would not be a very hippocampus-specific type of degeneration. All right, so this would be the typical outcome from our current application. So we asked the clinicians at the very beginning and before an MRI scan is available, how likely they think it is that the person will convert to dementia after a year, and then they will ask again after the MRI scan. And here the probability gone up substantially because it was such a typical AD-like scan. And the computer would also provide some rating of certainty. I'll skip this one now because we mentioned this already. So to conclude here, where I think the remaining challenges are that so far the majority of studies have focused on highly selected cohorts, you know, prepared, I mean, designed for treatment studies and very different from the clinical routine. And also I think the focus, methods-wise, the focus has to be on addressing poor image quality and the presence of additional brain pathology. For example, there's about one third of Alzheimer's cases also have substantial vascular pathology, which on the one hand side may influence the classifier accuracy, but also modifies the clinical representation of the disease. And always keep in mind the distinctions between the university setting and the GP setting. And again, the gold standard is the great challenge we have. And as you heard in the previous talk, integrating biomarkers at this level and knowing how sure you can be with your gold standard may help to improve these methods. Thank you very much.